All right. Good afternoon, and thank you for joining AMFP Chicago for our quarterly event. My name is Greg Parr with Langhammer Construction, and I am the current programs chair for the Association of Medical Facilities Professionals Chicago chapter. We're excited to have you join us today for this virtual event entitled Facility Planning for Pandemics, the New Normal. While we wish we could gather in person for this event, we had to decide as a group and as a community that the virtual format was more appropriate with respect to the healthcare of everyone and the healthcare systems. This session will be recorded and will be presented as a Zoom meeting, not a webinar. So we ask you kindly mute your phone, mute your camera, mute your microphones and the camera while the speakers are presenting. For the best viewing experience, please click the view button at the top right-hand corner of your screen and set to speaker mode. You will be able to submit questions through the chat icon on your Zoom bar, and we will be reviewing those and asking those to the panel a little bit further on in the session here. There will be breakout sessions following today's panel discussion, where we'll be able to participate in individual Q&A with the panelist speakers. At that point, we would encourage you to turn your cameras on where you can have a more candid conversation with the speakers. But until then, we would ask you to keep those off. After about 20 minutes or so of the breakout sessions, we will return back to the main meeting room, where all the speakers will conclude with their final parting thoughts, and we will continue with group Q&A. Thank you to the board, committee volunteers, sponsors, chapter membership, and all who have participated in the community over the past year. If you're new to AMFP Chicago, we have an exciting 2022 schedule of programs and events ahead of us, and we are so thankful that you can join us today on this first program of 2022. The Association of Medical Facilities Professionals Chicago chapter is a place for healthcare built environment professionals to call home. Discover a collaborative community where members can network and unite to share best practices and learn from one another. With over 780 followers on LinkedIn, our LinkedIn page is a great source for connecting and staying updated with our upcoming events. I'd like to share with you some of our upcoming events and the overview of our 2022 schedule of programs. In April, we have a program entitled The Future. The effects of technology and on medicine. Our May event, we are partnering with squarefootage.net for a summit. June, we have an urban healthcare design program. And September, real estate solutions for healthcare. And then in December, we have our members only Merry Mingle, which if you were at the one in December, was a very memorable experience. If you're interested in learning more about becoming a member of AMFP, we invite you to join us at one of our upcoming cocktails and conversations held the third Wednesday of every month. Please reach out to a committee member for more information if you're interested. We would also like to thank our sponsors for their support over the past year: Bear Construction, Harvard, Boz, Hayworth, Barton Mallow, Low Voltage Solutions, and SM&W. Without their support, programs such as this would not be possible. If you're interested in a 2022 sponsorship program, packages are available. As mentioned previously, you are able to submit questions during our panel by clicking on the chat icon on the Zoom bar. We'll be monitoring and consolidating the questions for our presenters and answering them at the appropriate time during this presentation. Following the event today, you will receive a survey. Kindly complete the survey and we'll send you a link to the recording of this event along with a copy of the presentation and any unanswered questions. These assets will also be made available on the website. Now, at this time, I'd like to introduce today's panel moderator, Steve Nargang. Steve Nargang is a principal of the Chicago office for TLC Engineering Solutions, a top 10 national healthcare engineering firm. Mr. Nargang is a professional engineer with project development leadership, combined with 25 plus years of design engineering, project management, and development at primary healthcare facilities over the past 12 years. Steve is active with AMFP, AIA, ASHI, HESNI, and has served on the board of multiple associations. Currently, Steve is the vice president of the AMFP Chicago chapter and IIT ambassador for the Lean Construction Institute Chicago Education Committee. At this time, I would like to hand it over to Steve.
Thanks, Greg. I'd like to talk about the topics that we're going to discuss for this panel. It's a very topical subject, and we have very experienced facility directors to talk about these topics. When COVID-19 crisis hit the U.S., really the full impact was unforeseen and caught most hospitals truly unprepared. The level of disaster planning and preparation varied greatly among hospitals and systems across the country, with hospitals struggling to handle the patient surges. Designing for resiliency really came to the forefront. Architects, engineers, designers, we all developed solutions to help the medical facilities that were most impacted. Some teams actually designed conversions of structures such as hotels and convention centers and converted those into patient care centers. Other teams developed strategies for the next pandemic and most likely what would become the new normal. This panel discussion will review these topics and these subjects and the strategies and solutions that carry facility planning forward. And with that, I'd like to introduce our esteemed panel of speakers joining us today. We have Kurt Martz. Kurt Martz is the Regional Director of Facilities for AMITA Health System, including the Adventist hospitals in the Chicago area. He has responsibilities across a 4-campus system in the Chicago area. With over 20 years of healthcare experience, Kurt is known for his expertise within construction, safety, engineering, capital planning within the healthcare sector. Kurt has been involved with the American Society of Healthcare Engineers, ASHI, HESNI, and recently transitioned out of the role of president for the local chapter. Then I'd like to introduce Saliba Kokali. He's the vice president of operations at Swedish Hospital, which is part of the North Shore University Health System. Mr. Kokali serves as the Swedish Hospital's chief safety officer and oversees their safety management program. In addition, Mr. Kokali is a consultant for the Accreditation Commission for Healthcare, ACHC, the Health Facilities Accreditation Program, HFAP, in which he does life safety reaccreditation surveys per the Center for Medicare and Medicaid Services Standards for the hospitals throughout the U.S. Mr. Kokali is a member of ACHE, is currently serving on North Park University School of Business and Nonprofit Management Advisory Board. Most recently did a presentation named Cultivating Excellence in a Changing Healthcare Environment. Mr. Kokali serves also on the Bietsor USA Board of Trustees and a member of their executive committee. And finally, we have Ray Lebrecht. Ray Lebrecht is the Associate Vice President of Facilities Management for Rush University Medical Center. He serves on the AMFP Chicago Board of Directors as Vice President. He is a licensed architect who has performed many roles in healthcare design and construction, including medical planner, design manager, program and construction manager, and facilities executive. He currently oversees design, construction, and corporate real estate for RUMC, including the new Joan and Paul Rupslager outpatient building and the Rush Specialty Hospital. Thank you very much for to our esteemed panelists for joining us today. Now I'd like to turn it over to them or include them as part of this panel discussion. And we are going to have this an open discussion and discuss some of these topics that we just reviewed, and look forward to getting feedback from each of these speakers. What I'd like to do then is give each of these gentlemen an opportunity to discuss, kind of give us a general background and feedback on their facilities and how they've approached these challenges. So beginning with Kurt. Kurt, can you tell us a little bit about your situation?
Yeah, no, thank you, Steve. And I want to thank the Association of Medical Facility Professionals to include me in this topic. It was hard to believe. I saw this yesterday, and the timing of this is well, I wouldn't say anything's perfect about COVID, but the timing of this is unique. I was watching the news last night, and many of you probably already know this or remember this, but our first patient that presented himself with COVID was exactly a year ago yesterday. And if my memory serves me correct, it was right here in the Chicagoland area, one of our hospitals up in the Northwest. It's so, I think it's changed all of our lives, and certainly changed how we do business in healthcare these last 2 years. And what seemed like a kind of a punch to the face 2 years ago. I always want to be careful when I'm talking about these things around our clinical teams, because it probably still feels like a punch to the face to them. But we handle things so differently today. There's a little different confidence in our facilities and what they can handle and what they can't. So, my story, as Steve said, I'm Kurt Martz. I oversee 4 campuses that fall underneath the AMITA umbrella. All the campuses that I have kind of influence on are in the suburban setting. All smaller to mid-range sizes, I guess from the range of 132 beds to 260 bed hospitals. So none of them large by any means. But as we went through the whole process on what to do, our campuses act very differently, and I think many of us can share those stories across all of our buildings. Just because of the age they were built or the mechanical systems that were in there, it's just very different on how you handle certain things. So we learned a lot in the last 2 years, and what we could do with certain campuses, what we couldn't do, and maybe to some extent what we shouldn't do. So I think some of the topics that we will talk about today will probably touch on all of those. I do want to thank Steve. They always tell you surround yourself with smart people or more intelligent people. So I love this group, because with Ray, Mr. Saliba, and Steve, I certainly have surrounded myself with much smarter people. So I'll turn it back over to you, Steve.
Thanks, Kurt. Appreciate that. Saliba, can you give us a few comments on your situation there?
Sure. Thank you again, Steve and the AMFP Chicago for giving us this opportunity to present and discuss, exciting topic and very important topic that impacting the globally everybody. At Swedish, we joined North Shore in December 19. And after that, in February 2020, I went on vacation to Cancun. I came back, and then all of a sudden, March, the COVID hits. And it is like, what the heck happened with this world? Things totally different. We started getting called to meetings and to talk about this COVID, which was really a surprise to everybody. But I could tell, being part of a system, I think it really helped us a lot. Swedish has been independent hospital for over 135 years. And being part of a system, I think sharing the resources and working with 9 hospital system right now, it really helped us to survive and go through this. And I think the major thing that helped us going is the culture at Swedish, that our leadership, what they went through and how they brought the whole team together. It really helped the staff to keep going, because it is not just about, buildings and infrastructure and do you have this, do you have that. I think it's about the leadership and how you could keep this thing going through such a pandemic that everybody was trying to learn about it, to see what we need to do, how many negative pressure rooms we have, how many that. This is, beyond that. I think our leadership did a great job, and we were excited to be part of the North Shore system because as a large system, we did really help each other, support each other, and learn from each other, and this kept us going. So in a nutshell, this is not the worst pandemic. There was worse pandemics than this before. I think we are lucky, but now, with today's discussion, we need to have a pandemic strategy because luck doesn't really help us.
Thanks, Saliba. Ray, a few comments about your situation.
Sure. Ray Lebrecht, as you said, I'm Associate Vice President of Facilities Management here at Rush University Medical Center. As far as the system goes, I really concentrated my efforts here at Rush, at the Medical Center. We also have Rush Oak Park and Copley, which just actually recently became a system. We had a strong affiliation, but not actually a system on paper. So, one of the things I saw on your statement, and I'll kind of agree with what Saliba said, is, you talked about caught hospitals off guard. I think that depends on the hospital and the system and the hospital. I think one of the things that we're lucky at Rush is the new Tower Hospital that opened in 2012 was designed for, let's say in our emergency department, was designed for advanced emergency response. It was actually the McCormick Center for Advanced Emergency Response, which focused at the time on bioterrorism and mass casualty events, but technically this falls in there. So, everything that we had to do is, as far as accounting for this or accommodating this new patient flow, we were lucky that we had a lot of things in place for that to happen. So,
thanks, Ray. Well, I appreciate getting kind of a general idea of where you are and how you've been dealing with this. I'd like to dig a little deeper into some of the issues and some of the subjects. And I guess the first thing is, when the crisis first happened, it really caught almost everybody unprepared. I guess some of your facilities were more prepared than others, but what would you say, and this is a question for the group, what would you say was the main initial challenge where you were caught unprepared or just not ready for the initial crisis?
Well, I'll take that one. I think initially it was the number of patients. We're actually talking about, we've had multiple surges, right? So the difference between the first surge was the unknowns of COVID, how to treat, how it was transmitted. So there was an initial reaction to that was much different than this Omicron surge that we had as of late. So the unknown part of it was the difficult part. So the not knowing how widespread this is going to be, how many patients we were going to see, I think part of it was maybe we swung a little too far, but at least we were ready for. We brought on. Well, first thing we did was we spun up our emergency response. So we have a entry pavilion that we can turn over to patient care. So we were scrambling at this time for some partitions to set up patient bays for non-COVID positive patients. We can get them out of the ED so the ED can concentrate on COVID patients. And we had an area in our atrium building that we just started stockpiling beds, regular beds and ICU beds. We were thinking that we might have to double up patients in rooms. We were looking at turning our prep recovery areas into ICUs. So we were getting ICU beds in there. We had three-sided bays, so we added shower curtains to get some separation. We were adding power in corridors, actually on the patient floors and in our prep recovery areas, so that you can move equipment out of the patient room, so you don't have as much back and forth, opening that door, staff going in and out. So I think it probably happened in most hospitals. We had pumps and physiological monitoring in the corridors. So a lot of that was happening, and so that was I think our initial anxiety and reaction was, let's get ready for more patients. So like I said, we were spinning up prep recovery areas. We took 3 of the floors in our bed tower, and we turned them to 100% exhaust. So basically, you're creating a negative floor, and that's where we spun up the COVID response floors. So that's where we kept the patients. One of them was ICU and 2 acute care floors. We took a number of the units are, we have beds in about 4 different buildings. So we took one in our rehab building. We switched that over to med-surg overflow so that we could take care of more of the COVID patients in the new tower building rather than some of the older buildings.
Thanks, Ray. Kurt, what was the initial?
Yeah, no, very similar to Ray. Early on, prior to the first kind of, surge, we had the first couple of patients come in January, and then we really didn't see much, at least in the campuses that I oversee, until that March date. And so this whole time in between there, I think the leadership teams, you're kind of planning, but you don't know what you really, the numbers that you're going to be dealing with. So I think what happened in our area is we went from 0 to 100, that quick, like probably most organizations. We had an assisted care living center down the street from 2 of our campuses. And so I can remember it like yesterday, on a Friday afternoon, walking down the hallway and seeing our IC nurse walking towards me. You can always tell by the pace of their walk. And she just looked at me and said, "It's here, Kurt." And then immediately at that point, we started hearing the numbers that were coming in. And back then the numbers, 12, 13 was a lot, because, when you're, the initial plan was put them in your isolation rooms. Well, hospitals of my size, you have 13, 15 isolation rooms, and if half of those were already full, you fill up those pretty quick. And so we quickly realized this is beyond isolation, and then, so again, because of the different ages and mechanical systems in our building, some of our newer towers, we could, bring in a lot more air. We were fortunate that it was March and not July or today, January, where we could bring in 100% air and exhaust 100% air. We were just fortunate with that timing. And so we did that to a lot of our sections of the building. Wouldn't say they were truly isolation or negative, because as you know, in most design hospitals, as you start to pull air from one area, you're pulling it from something else. And what we learned pretty quick is we started to manually adjust some of our rooms that we had limits, and we started impacting isolation rooms. So we knew at that point we could only adjust, we can only ad hoc, I guess, so many rooms. And so we learned that pretty quick. And so I think that was kind of the big difference on that first phase, is us learning the limits that we could push, that on this second phase, here in the last few months, we kind of knew. And so we kind of jumped right into that. But those are kind of the things we saw, very similar to Ray early on.
Thanks, Kurt. Saliba, how about you?
I think, same thing as, Ray and Kurt did at their facilities. I think what we did that time, what the hospital did, the first thing, we activated our HICS center, which is the Hospital Incident Command System. which is really brings all the different department managers and the ID team, the infection disease team together. I think this whole process was led with them. We did get direction from them, what they need, what we should do. At the beginning, we had like 24 isolation rooms. They were scattered through the whole campus. We were wondering where to put patients. Should we spread them or we should put them, in one area? So as Ray mentioned, they have towers. We have 4 towers at Swedish. We decided to convert 1 tower, make it all negative pressure. And we converted the whole tower and we started, adding patients there. At our peak, we had roughly 150 patients, COVID patients. So that was the most we did get through the pandemic. And then after that, if we needed to have more patients, what we did, as I said before, when you are part of a system, the North Shore University Health System, they converted the Glenbrook Hospital to totally COVID hospital. So if we need to send patients there, we were able to send it there. So that was really a big relief for us because, we have capacity, we have patients. The problem is that we don't have enough, labor, which is mostly through this whole pandemic has been a big time, is the labor shortage. It's not just about caregivers, it's also about housekeepers, about everybody. So, but the nurses were the most critical. And if we couldn't treat these patients or one unit gets infected and we have to close that unit and nurses has to go home, that would be a problem. So we focused through the HICS meetings, on the PPE. That was a major thing that we did really face at the beginning. We were still part of the system. We're new, but we were purchasing things on our own. And, we gave to the different VPs and different executive different roles in this pandemic. For example, myself, I was in charge of the supply chain. I was making phone calls to China, to New York, to wherever, to the governor. We're trying to get PPE was really a major thing. So facilities, we have the tower, it's negative, it's protected, but you need other things to support the staff because you want to be sure that the staff feels safe, that they could work in a safe environment. And you have enough labor to support the staff. If the rooms needed to be cleaned, you have enough staff. We were, housekeepers was a problem, but people did get cross training. We had, people, staff from maintenance help out with that. So the whole team came together. It was rough, but I think working together and working part of the system really did go a long way. The first year, 2020, it was very hard with the PPE, but then that was figured out, and hopefully, moving forward, this issue will go away, and hopefully there will be more companies will manufacture PPE in this country. Right now, so far, so good. We are stabilizing with COVID patients currently at the hospital. We were at the peak a week ago, and now things going, slowly getting better, slowly but surely.
Let's talk about the facility planning as far as upgrades, revisions, expansions, changes. Talk about how you engaged your design and construction team, including your architecture, engineering consultants, your contractor consultants. Talk about how you engaged those teams and decided on a plan of what changes you needed to make. Ray, could you tell us about that?
You're talking about changes during the first wave?
During the first wave, and then continuing on from there, how did you change your facility planning and upgrades plans with your team?
Well, it's interesting because during the initial surge back in 2020, we actually shut down all capital projects unless it was mission critical. We put shovels down, hammers down everywhere. And also the Rupschlager project, which is a 500,000 square foot project, we had to take all our institutions took a serious hit in cash flow, as we're closing down elective surgeries and outpatient visits. So that initial focus was really just focusing on how do we keep this facility running. Now, moving forward, it did bring up questions, mid-construction, we're just getting going really on the superstructure on the big building, is do we need to address anything in the planning of that building for the mechanical systems we had? And we can get into some of that later. So that was kind of the initial change. The other thing that we looked at is, as everyone went work from home on the administrative side, that really had us taking a look at, we're getting those people up and running and getting them, making sure that they have the IT that they need to work from home, the connections. Do we give them a stipend for, their internet connection, all that kind of stuff. But we started to question, well, do they need to come back? And we took a completely different look at the way that we deal with our administrative staff, billing and call centers and all those on the finance side, on the IS support side. So as far as planning for the space we had and future space, we came up with systems to keep people working from home. That's really more of a management operational task than it really is a facility task. We're clearing out space. So we started looking at some of those administrative space, and it gave us actually the perfect opportunity. We have a building that we wanted to tear down. It's 40,000 square feet of administrative space. And we were able to clear out enough people that permanently work from home. We started condensing some of those departments, so we could get rid of this building. So we were able to, on a facility side, just changing that strategy, like I said, we could decommission 40,000 square feet, and it allowed us to discontinue some off-campus leases too for some of these administrative spaces.
Thanks, Ray. Kurt?
Yeah, we were, it certainly altered how we were doing some buildings. We didn't have a lot of huge capital on our plate, but we were in the process of designing a build out on one of our smaller campuses, and it did alter how we actually did that patient care area with different mechanicals to where we could support a negative environment under any condition, and just the room layout. So nursing came back and really wanted to see the patient without having to walk into the room. And so there were some vision panels that were added. They actually flipped the room around, which is there's a double-edged sword on that one, to where from the door side you can actually see the head of the patient. There again, there's some conflict with that because it doesn't, not the most patient private at time, but for what we needed, it worked out good for our clinical teams. And so it turned out to be a good project. The timing of it was perfect. We were in the design early on, hadn't committed to anything, and were able to make some of those changes. As you know, certainly once it's designed, it's as good as built, or there's going to be change orders, but we're in that kind of sweet spot of design to where we could really work with our architect firm and engineers to make some changes. And then again, with what Ray talked about, certainly saw a lot of changes in just what the needs were for our support teams as far as office support. We've seen a lot of those capacities, shrink down, and I don't know if that we're ever going to be bringing people back full time. I don't think that's just healthcare. I think we've learned that in society. I'm such I always want to be in front of people and see the whites of people's eyes. So I'm not used to it. I struggle working from home, but I realize that's not, I think it's getting more and more normal. So a lot of those spaces that we had people in is certainly game to be redeveloped in our campuses. One nice thing about that is we are so landlocked on most of our campuses and certainly in all of our areas that it does create opportunity for us to do something a little different where we had a lot of the support services.
Thanks, Kurt. Saliba?
Yes, we did the same thing, similar things. I think the major things that we did, there is 2 floors in our east tower that we totally originally converted to negative pressure. We made 2 floors, 32 beds. We installed HEPA filters, so by flip of switch, you could go from the normal mode to the pandemic mode. So in the future, whenever we need these rooms, we could convert them easily. I think this is something, engineers for the future. I know we don't think about redundancy, but these things happen. We don't know what they're going to be the next pandemic, what we need to do. But something like this, it should be done originally. But, things are different now and we are learning, which is great. And this is what we did. Other things we did, regarding waiting areas, we reduced the number of seating, and we told patients and their families and visitors to wait in the parking garage. We made the parking garage as an extension of the waiting area, so they are not crowded. I think the other thing that we focus big time is the well-being of our staff. We wanted to be sure that our staff get a chance to decompress. So we converted some of the waiting areas for the families because we had restricted policy for a no visitation policy. What we did, we converted these areas for respite areas for the staff. So it is a waiting area on the same unit. A nurse or a physician or other staff from that unit can go decompress. A nice environment. We put massage chairs in these rooms, some nice lighting. I think this really goes a long way to help the staff, because when the staff works 12 hours or sometimes they need to work double shifts, that's something very important to let them know we care about you, we support you, whatever needs to be done. So many of these things will really stay for the future, because really they are important. In the old days, because of landlocked and, designing things that are lean and efficient, we forget about these things. But right now, these things really are needed, and we encourage, architects and engineers to think about that and keep us in mind. I think it is wise to spend the money up front, but long term, it can be really helpful for the staff and for the hospital and make things go smoother. Other things we did, as Ray said, some of the areas for the staff who doesn't really need to be on campus, we give them remote access, and we use their offices for either PPE storage or for, to make it an area for the staff to go and decompress in it. We try to make the prime space on the nursing unit as efficient as possible, and give a chance to the staff to take advantage of these. At the same time, during this, we went and gave the staff, we did walkthroughs, leadership. I just want to keep in mind, we could talk about mechanical systems and stuff like that all the time, but I think getting the staff to and support them, it is as really important as building systems and converting things. I think the staff feels safe when the leadership talks to them. So you could change the negative pressure rooms, we could do all that stuff, but I think the other stuff that we do for them goes a long way.
Yeah, I'd agree with a lot of what Saliba just said. Is all those things that we're doing for the staff, I think a lot of them are going to stay. A number of things that you mentioned that I put down was respite areas. The other thing is, healthcare delivery is such a collaborative effort. These people are always in workrooms together, nurse stations together. They're always kind of packed close to each other. Now that we're in a time of social distancing, how do you do that for these folks? How can they get some elbow room and get away from each other so they can maybe take the mask off for a little while, during the day. So we
Exactly.
did add a bunch of break areas and some, we had some connections between the new tower and the existing tower they were very wide, say 16-foot wide bridge corridors that had some nice views from them. So we put a bunch of lounge chairs in there, spaced them out, and they're still there. I remember because my team was physically moving all these things. You figure you got a group of capital project managers who aren't working on projects. So we and other volunteers became the ones setting up all these areas. So we did a lot of that for respite. And you mentioned also the communication between management was huge too. We actually, so when we stood up our HICS too, part of that was, well, initially we stood up the HICS and the way it usually happens, it was in a boardroom. And so at maybe the second or third day, we looked around the room and saw 50 of us crammed in there to manage all this stuff. We said, maybe not a good idea. So we actually broke that up into about 4 rooms, for supply chain versus senior management, facilities, communication, and marketing. So one of those rooms we used for management could check in, and we would actually do management rounding on all of the floors that we'd go through, talk to the staff, talk to the nurse managers, and make sure that they had the PPE that they needed. Was there something missing, something that didn't work, anything that management might not know about? That went a long way, and that was operational as opposed to facilities.
Thanks. So now that we're 2 years into this, what have you learned recently, maybe over this year, that you would have done different the first year? And what would you say are some of those major learning experiences that you've gone through that you would do differently? That's open to any of you who want to chime in and talk about lessons learned.
I could take that, Steve. So, one thing we did, like in 2007, we expanded our ED. We built our ED, we added more exam rooms. And at that time, we had a larger waiting area, and we felt, oh, this waiting area is too large. We don't need this. We should work on the throughput. We could get patients inside, and we added more exam rooms. But with this pandemic, we realized that really it's a big mistake. Your waiting area needs to be large, especially with social distancing now. And although that time we added 11 exam rooms extra, but still, if you don't have labor, if you have shortage of nurses, if you cannot get the throughput, if you cannot put these patients who come to the ED, if you cannot put them, into these exam rooms, that's a problem. So this is one mistake. If I do the ED reconstruction again, I will keep the ED larger and also maybe subdivide it into an area where you could make it isolation. If you feel that there is a patient needs to go to that, you could separate them. Right now with this pandemic, we put outside the ED, we put a triage tent, and we put a tent also for COVID patients. But that was a problem because, it was hard in the winter time to keep the tent heated, to keep patients in a tent, which is not the best patient experience out there. Other things we could done it differently, focus in the design on the staff and the caregivers, build really on each unit, build a nice space for them to go and decompress. They need to have lunch, and right now they are crammed in a small area, or they have to go to the cafeteria. The cafeteria is also crowded. We reduce the number of seating. So I know space is prime, but we should really think about that in the future. Also, I think what I will do, with the exam rooms, we should look at designing them differently. That could be more modular because sometimes you need exam rooms that they are larger. You need to equip them with, the technology, especially these days with telehealth. and insurance paying for telehealth conference calls. Our exam rooms are basic. They don't have that technology. We need video conferencing. We need to be sure whatever setting that is needed in these rooms, that they are prepared. It goes a long way. At the same time, with the patients, we need to have the same setting with them at their houses to be sure that they get supported. They feel like they are basically seeing their primary care, similar environment, similar technology. So I think little things, but it goes a long way.
Thanks, Saliba.
Yeah, I think Saliba just hit it out of the park. I think what we've seen is just really the ability of having flex space, which again, when you design a building 10 years ago, you committed to that. You really got to defend it in place. And so I think as we put some thought into what we will do differently as it works through the construction time periods, is that you just design a little more flexible space. We're in the same boat where our waiting rooms, 10 years ago you were thinking about throughput. You don't want people in your waiting rooms. And that's really hurt us, certainly on the second wave. Now the visitor restrictions, those things kind of help, because whenever anyone comes into your ER, there's usually 2 or 3 of them all for one patient. Those things help. But I think we learned from that too on the first go around. I think early on, well, not early on, for a long period of time, we had no visitors. That's not good for your patients either. We know that, looking back that you have to have, we believe in visitor restrictions. Quite honestly, personally, this is Kurt March speaking, hope that visitor restrictions stay in some capacity forever, but it can't be no visitors. That end of life or expecting mother, these things, it's just too important to have that significant other, parent, whatever it might be, at the bedside. So, but I think that's helped our organizations too, is having some of those restrictions with space. And then I agree with the telehealth. I mean, technology. The one good thing that has happened is we really have relied on technology for the patient and for the things we're doing. I think it's very normal for us to have leadership team meetings today across many organizations. And there's those conveniences to where you probably don't necessarily need all those large conference spaces that all of our campuses have. So
Thanks.
Looking at those spaces and making some flex spaces there, I think is probably what all of us are going to be doing over the next phase of construction work.
Yeah, that's one thing that we've never really had is flex space. Who can afford to have space laying around not getting you income, right? So, but we were, so the planning for the new outpatient building, I mean, we were already in construction, so, we were pretty much set. But I think there was some happy accidents with some of these things. The new outpatient building is set up in care team modules, and not separate waiting rooms for each one of those modules. We have a long concourse along the whole south elevation of the building on each floor that is combination, space to move through and a space to wait. So, if you were to stand on one end, it would look like this, football field long waiting room sort of. So part of that is people can spread out when they're there. And also, we were really mostly focusing on reducing waiting space and concentrating on that patient work, moving the patients through. So that benefited us. But the other things in the building that we have is we'll have retail food options on the ground floor with more seating, and good weather outdoor seating. So these are places that those, the loved ones or who bring in a patient can go wait while someone's being seen or getting imaging or treatments. And then we also had a small conference center. So there's the kind of spaces that if you have several visitors, there's some place that they can go wait where we can socially distance some folks. One of the other things that I'm thinking of when I mentioned food options, that is one thing that we also did for the staff. We had to close down the cafeteria or the Panera, the all bon pans types of things. So we started looking at bringing food to the different floors. We actually we call it Room 500, our lunch club that created a cart that they could wheel up and serve the care team in the different break areas. So some of that flexibility in the future we're gonna keep an eye on too when it comes to planning.
Thanks, guys. So we've had a number of good questions that have come across the chat. We've got about just under 10 minutes here to handle a couple of those questions. And then what's going to happen is we're going to go into individual breakout rooms. So just after 5 o'clock here, we're going to have individual breakout rooms. Everybody that is attending today will get broke out into separate breakout individual rooms with each of the speakers. You can switch between the rooms once you're in a room. We're going to do that for about 20 minutes until about 5:20, and then we're going to come back and have a final wrap up for maybe 1 or 2 final questions for the group and wrap things up. So I want to hit a couple of these questions that have come in, and then if you post a question and we don't hit it, please ask the question during the breakout sessions if you can, and then if not, we'll try to hit it when we come back and when we all return back to the main room. So one interesting question here is, how much collaboration has there been between yourselves or with other systems? Are you sharing ideas between the different healthcare systems, and how's that collaboration been going?
I can jump on that one. I don't know how many know. So the AMITA partnership actually comes from 2 large national systems. And I will say this, and obviously there's some news with AMITA, but I will say this: for the pandemic, I could not have been in a better position. We had the Ascension Health on one side and Advent Health on the other, and the information flowed very nicely between my peers. A lot of my peers are on the MedExcel facilities management team, and that information flowed, and honestly from a national level. And so as we were seeing things, how it was impacting a lot of our hospitals in Florida, we could take that information. And so there was a lot of collaboration and sharing of information. So I will say this: I would not have wanted to go through this alone with just, my campuses. Again, I was joking in the beginning, but there's some seriousness to that. I'm never the smartest person in the room. I'm going to walk out of that room if I am pretty quickly. But I do rely on peers. And Chicagoland has great groups. I mean, the one we're sitting in right here, and I think we have some other good professional groups that you can lean on peers within the Chicagoland area. So absolutely, firsthand was reaching out to my peers.
Good. Ray, collaboration?
Yeah, I'd say it happened, like Kurt said, on all levels. I was staying in touch with facilities folks through, the Ben group of the Healthcare Design Network. And so hearing what they're doing and what they're facing across the country, because we were getting, all of us were getting these surges at different times, and we're able to help out and talk about, what I faced already and what's heading your way, so that was great. But then everyone from, and you'd hear about it on the Hicks calls in the morning, everyone from the CEO, the COO, the CNO, they're all talking to their counterparts around Chicago, and talking a lot about logistics and what they're dealing with. So again, like Kurt says, I am also not the smartest person in the room, and so it's great to be in that room with those folks, because everyone's attacking it from a different angle and talking about what they heard. So the collaboration internally and everyone reaching out was just fantastic.
Saliba?
Yeah, very similar. On the Swedish locally, our Hicks team met every day to discuss issues. learn about the issues that the staff is facing. At the same time, being part of the system, they have also the system, they have daily calls at noon for 1 hour, and they heard from all the different hospitals what each at that time, until December 21, we were 6 hospital system without the Edward Elmhurst system. So these 6 hospitals, we talked every day. Their situation calls. We discuss, how we could help each other, what issues each hospital is facing. When we discussed about the Glenbrook Hospital, that to make it, to convert it to a COVID hospital. So that was, known for everybody. We did work with them, we collaborate with them on sending them patients, stuff like that. So that was really great and very helpful. At the same time, with the city of Chicago, we are part of the city coalition. There was also weekly situational calls. You could ask questions. If you have issues, you could call. There is people you could talk to them. They help you out. So this was a really learning experience for everybody, but I think the city did a great job, keeping us on track. And also daily, we were supposed to be submitting, numbers to the city about, how many ICU beds, how many, ED patients we got. So all that stuff shared among the Chicago coalition hospitals, and also being part of the system, all that information really get routed to everybody. Everybody hears what's going out there. And, there's also the Illinois Hospital Association. They had also many calls. We used them to help them to call the governor during the PPE issues. We had PPE came and it was stuck in the customs in New York, and we couldn't get it. So we had the governor help to get involved. So being part of a system and working with other with other systems and the city and the IHA, that really goes a long way.
Thanks.
Maybe I can add one more thing
Go
to
ahead.
that too, and I'm sure we all had this. It wasn't just even the sharing of information, but really the sharing of resources too, because I can't remember, it might have been Ray that mentioned, we saw the waves going across the country in different time periods. And so we received large shipments of ventilators from Florida and sent those back, because the waves were different. And the same with staffing. We saw in the first wave, not the second one. I think everyone's struggling with staffing, but the first wave, we saw staffing coming up from the St. Louis area to help some of our Chicagoland market in that first wave. So the resources were good to share across the systems too.
Good. One final question here, just a few comments from each of you, and then we're going to do the breakout sessions. I've seen a couple questions here regarding updates to the IDPH requirements and FGI guidelines. Maybe if you make a few comments regarding your facilities and how you're dealing with changes with IDPH and FGI guidelines.
I honestly rely on the group that's probably out there for these things. I do know we did I know this doesn't answer the question, but we did opt into that 1135, which helped us with some of our testing and different things that we do in the healthcare industry. So so we did utilize that as a tool during the first wave, and really haven't utilized it in the second wave, but so we have used that, but I realize that doesn't answer your question, but I would rely on the group out there to help me walk through that process.
Sure.
Steve, anything specific about the FGI and the IDPH? I'm not sure if I'm clear on this question.
Sure. Yeah. One of the questions regarding IDPH is they required a permitting of occupancy changes for flex spaces, for example, and classification of those spaces. So has those changes affected your planning or changes to your facilities operations?
We haven't really done much construction during the pandemic, but I could say when we called the state for anything, they were really very helpful, very supportive. We built, big project was, we added 3 cath labs, and they didn't come. They trusted the architect, and they They let us open. They gave us temporary occupancy and then final occupancy. So the state were really very reasonable and did work with the hospital system, which is really great. And I would like to thank them for that.
Thank you. Okay, I think at this time we're gonna switch our program to the individual breakout rooms. I know a lot of people still had other questions, so if your question was not addressed, please do it in the individual breakout rooms. What everyone is going to see, you'll see a pop-up window that will appear at the bottom of your screen, and you're going to have the option of joining the breakout room. And then after about 15-20 minutes, right at 5:20 actually, we're going to return back to the main room and then have some maybe one or two parting questions, final thoughts, and then close out the event at that point. So at this point, we will be starting the breakout sessions, and you will see that message on your screen.